It's a great pleasure for me to welcome Dr. Vivek Matthew, Head of Neurology, who has very graciously agreed between his busy schedule to come and do a clinic for us. Sir's the current head of neurology and his area of special interest is epilepsy. Thank you so much, sir, for coming. And today's presenter will be Lino. Unfortunately, we were not able to bring the case here today, but I'm sure that we will be able to have a very good discussion. So thanks everyone for coming. We'll start the clinical meeting.
Good morning, everyone. I'm Dr. Lino, presenting on behalf of Medicine Tree and Balance. This is Mr. X, 61-year-old gentleman, pharmacy owner from Tiruvarur. He informed his patient himself. He presented to us with imbalance while walking for 10 months, slurring of speech for 4 months, difficulty in swallowing for 4 months, talking in sleep and making actions during sleep for 3 months, and tinnitus for 3 months. He was in his usual state of health before 10 months ago, when he could go for cycling every day for at least 30 minutes. 10 months back, he developed difficulty in balancing the cycle, especially while turning towards left side, following which he stopped riding the cycle and started walking. This is time when their family members noted there is a change in the way he was walking. He started walking with his legs wide apart and concentrating more on floor while walking. His pharmacy is almost 1 kilometer far away from his house. He uses motorcycle to go and come daily. But before 6 months, while lifting and placing his right leg over the motorcycle, he loses balance and sways towards left. And he had one episode of fall during this. Following this, he changed his motorcycle to scooter. He generally wears his undergarments by standing, but since last 6 months, while standing and placing one leg inside, he sways. This was initially only in the left side, but since 3 months, he had faced difficulty while using the right leg as well. He generally takes bath by standing, but since last 3 months, he noticed swaying while closing his eyes. So currently, he takes bath by sitting in chair. There is also history of difficulty in negotiating narrow pathway. There is also difficulty in imbalance is more while navigating uneven ground. There is no history of tingling of limbs. There is no history of paresthesia, numbness over the foot. No history of slippage of slippers or difficulty in holding slippers. No history of difficulty in squatting or getting up from squatting position. No history of vertiginous sensation. Almost 8 months ago, when he attempted to withdraw money from his bank, his check was rejected because his signature did not match on the file. Writing poem was one of his hobby, but over past 8 months he stopped writing because he became slower in writing and the size of his handwriting became smaller. However, there is no tremors, there is no difficulty in buttoning or unbuttoning shirt, no difficulty in bringing food to his mouth or smearing of food on face, no history of rising head for pillow. From last 4 months, he experienced difficulty in swallowing both to solids and liquids, which was insidious in onset and gradually progressive. He feels like food is getting stuck in throat and he drinks water to alleviate the sensation. However, on drinking water, he develops nasal regurgitation. 2 months ago, even he choked on food and experienced decreased responsiveness. His son has perfumed helmet manual, following which his symptoms resolved. These symptoms are only occasional, but he still continues to take oral feeds. However, his food intake is decreased because of these symptoms. Since last 4 months, he also noted slurring of speech, making it difficult for him to communicate with family members. He has to repeat the sentences twice or thrice to make them understand. But he is able to complete the sentence. There is no gap in between the words. No change in volume. However, fluency worsens as he keeps talking. He is able to comprehend, able to read, write, name, and repeat words. His wife, who sleeps in the same room, noticed since last 3 months, he talks during sleep and he makes actions like punching and cycling during sleep. However, there is no tremors, no slowness of activity, no recurrent falls, no alien limb phenomena, no abnormal posturing of hand or memory disturbances. He also complains of tinnitus for last 3 months, which was continuous, not localized to 1 year. not associated with decreased hearing, ear discharge, or ear pain. He also complains of increased frequency of urination with urge incontinence and sense of incomplete evacuation of bladder for last 1 year. There is also a history of constipation since last 1 year. He uses daily laxatives and Ayurvedic medication for passing stools. However, there is no history of abnormal sweating, dryness of skin, or postural giddiness. There is no history of loss of smell, double vision, drooping of eyelids, difficulty in chewing food, or decreased sensation over the face, or deviation of angle of mouth. There is no difficulty in turning head to side, or striking of shoulder. He is able to feel cloth sensation, insect bite, warm or cold temperature while bathing on both sides of the body. There is no history of psychosis or auditory visual hallucinations. There is no history of loss of consciousness or seizures in the past. No history of loss of weight, loss of appetite. No history of headache, vomiting, or seizures. There is no history of loose stools or abdominal pain. No history of chronic cough or blood in sputum. Past history, he is a known case of type 2 diabetes mellitus for the last 3 years on oral anti-diabetic medication. He is also a known case of bronchial asthma on metered dose inhalers. Treatment history, details of what medication he has taken is not available. However, there is no improvement with the treatment over 10 months. Personal history, he is an occasional alcohol consumer only once in 6 months, and he is non-vegetarian by diet. Family history, his father is a known case of myasthenia gravis diagnosed at the age of 60, was on pyridostigmine, and he is also known case of bronchial asthma. There is no history of similar illness in family members and no family history of malignancies. Summarizing, this is a 61 years old gentleman presented to us with chronic progressive imbalance, which was asymmetrically in onset, initially in the left side and then involving right side, while walking and incoordination, with bulbar symptoms in the form of dysphagia and dysarthria, with bowel and bladder symptoms, tinnitus, and REM behavior, sleep behavior disorders. So,
okay. So we'll have to go back.
yes.
So thank you, Dr. Ramya, for having me here. Dr. Sanjit is the head of neurology, not me. And Lino has already done a posting with us in neurology. So Lino, we have to analyze the symptoms, right? So go with it one by one. So is there anything unusual over here?
Imbalance. He initially started with imbalance while driving cycle, sir. That too, especially while turning the cycle towards the left side.
Okay, then.
So then, following which, the relatives noted change in his gait. He started walking with wide base gait.
Which is there? There's one sentence over here, or one part of one sentence which doesn't fit in with the rest of the story. In just this one slide. The last thing that you written, concentrating more on the flow while walking. What are you trying to imply with that?
He's trying to compensate for the imbalance.
Okay, so which kind of imbalance can be compensated by concentrating more on the flow?
Sensory loss of proprioception.
So so proprioceptive impairment is something that we can compensate reasonably well by looking at the flow. Cerebellar, not as much. So once you say that, you're trying to imply that. So this first slide gives the impression that we're talking about something which is like a proprioceptive impairment, right? Whereas that's not what you've. No. The rest of the story doesn't go with that.
Yes.
Once again, this same theme comes in when you said about bathing. He has difficulty closing his eyes while bathing. So it's not necessary. It may be that he has both. He may have more than one area involved, but that you will have to substantiate that on examination when you come to it. Yes. So otherwise, is in balancing the cycle while turning towards the left side. So just out of interest, have you thought about it? If suppose somebody develops an imbalance, will they have more problem with walking or with cycling?
So walking.
If it is with cycling, what aspect of the cycling is likely to be more difficult? Getting onto the cycle, getting off the cycle. On the cycle itself, they may not have as much problem. but they will have significant difficulty getting on, getting off the cycle, because of which they may stop cycling very early into the illness. All right. So there was a change in the way he was walking with his legs wide apart.
Yes.
Why is that important? Legs being wide apart?
So in sensory, there'll be high stepping gaits.
No, the legs wide apart.
In coordination.
Oh, okay. Why does anybody walk with when when do the legs become wide apart? Anybody with any sort of imbalance will tend to to try and make the center of gravity a little bit more stable, will tend to bring their legs wide apart. In fact, the question is, which patients with imbalance do not have their legs wide apart, with imbalance or difficulty in walking? Each of these things is important. Right? So is something that I've told very frequently. This symptomatology is the most important. Understanding the symptoms, deciphering it in anatomical terms, is the most important aspect of internal medicine itself. The first volume of Harrison's is almost entirely symptomatology.
Secondary to extrapyramidal imbalance, secondary to extrapyramidal usually close, short.
Okay, yeah. If they may not have a very wide base gait. Okay, more than that, which patients tend to have narrow base and still have difficulty in walking?
Spastic.
Yeah, so spasticity, they may in fact have scissoring as well if it is really long standing. But Parkinson's, only the idiopathic PD patients, who tend to have a short shuffling gait, they may not have a wide gait. But that's about it. Almost everything else, all the way from frontal apraxic to vestibular to cord to neuropathy, almost all of them will tend to bring their feet apart to be able to maintain a better balance. Okay. So another good thing was that you gave an idea about his daily schedule and how it got interrupted. And when you gave this chief complaints, you talked about imbalance, speech, swallowing, sleep, and tinnitus. You didn't speak about upper limb. Let's go to the next slide. What are the upper limb symptoms that he had?
So before 8 months, first noticed in a bank where his check got rejected, telling his
So his handwriting
signature.
changed.
Yes, sir.
So
It became slow and the words became smaller in size.
what do you want to imply by that?
So,
What are the types of changes in handwriting with progressive problems in the neuraxis?
so in cerebellar, if the associated tremors, their handwriting may not be, he may not be able to complete even the sentences.
But you written no history of tremors, right?
Yes, sir. There is no history of tremors.
So what was the change in handwriting due to?
So
what is it likely to be due to? How do you approach it? So somebody gives a symptom, you're thinking along lines of anatomy. Which part of the anatomy is involved?
Can be secondary to pyramidal, sir. Weakness of the hand per se causing difficulty in writing. But he has no weakness.
No, you read two things about his handwriting.
Yes.
It became slower in writing and the writing became smaller.
Yes.
Why would the handwriting become smaller? Slower can be because of compensation. He's having difficulty, so he's or kind of subconsciously slowing down to write it. But why would a handwriting become smaller? In cerebellar, what happens?
May not be. It will not be clear. So words will not be clear.
Yeah, it can be irregular.
Yes.
But when does the handwriting become smaller?
So extra.
To be more, see, to be able to write, we have writing is a fine function which requires us to coordinate agonists and antagonists. So if we have a dystonia or a situation where you're having the agonist and the antagonist contracting simultaneously or not able to relax the antagonist well enough, then you have what we call as a rigidity. The tone increases in both the agonist and the antagonist equally. Then as they keep writing, the handwriting becomes smaller, and also they have to exert more force as well. So that is something that you can pick up. So it's a indirect marker of rigidity. So when they have tremors, the handwriting will be irregular and but not necessarily smaller. So this what you're telling over here is indirectly referring to some amount of rigidity.
Yes.
it's not common for spasticity to have this much problem, but they may have more difficulty with gripping of the pen or maneuvering it. Those kind of problems they may have. But if the handwriting is otherwise just becoming smaller and becoming more firm as they continue to write, so it goes off ends in a squiggle. So that's kind of thing is seen more with rigidity. Okay, so each of these things that you are talking about becomes important. Then go next. You spoke about swallowing both solids and liquids,
Yes.
but using water to elevate the sensation. So, what do you want to tell about this? So, how do you approach somebody when a patient starts telling you about difficulty in swallowing? How do you start thinking about it?
It can be secondary to mechanical local causes. In that case, it will be more of solids. There will be pain associated difficulty in swallowing.
So have you read you looked at the chapter on swallowing problems or dysphagia in Harrison's? How do they begin? Actually, that's how we have to analyze any symptom. We should know what is the normal swallowing. So what are the phases of swallowing?
Mixing the oral starts with the oral cavity. So mixing food in the mouth and then propelling it down the.
Yeah. So where does he seem to be having a problem?
So in the propelling the food down.
Right. There are a few inconsistencies over here. Now, thinking along those lines, can you pick up what are the inconsistencies here? What does it mean after drinking water, he develops nasal regurgitation? What does that imply? After drinking water, he develops nasal regurgitation. What does that mean? In just simple anatomical terms.
Bulbar weakness.
No, what does nasal regurgitation mean? Why do we not normally have nasal regurgitation? What
Gag.
It's not that complicated. It's just straightforward. So, what are the parts of the pharynx? Nasopharynx, oropharynx, laryngopharynx. So, what separates what cuts off the nasopharynx from the oropharynx during swallowing? It's just anatomy and physiology. It's that nothing, thing. So, what moves up? The soft palate moves up. Then pharyngeal constrictors, together with the soft palate, separate the nasopharynx from the oropharynx. So, if there is a definite history of nasal regurgitation, generally it implies weakness of the soft palate and the upper part of the pharynx. So that's reasonably. So you have to be very clear about it. Is it a definite symptom, or is it something plus minus?
It is very occasional.
Very occasional. So then it could be coming from the other part of it. You said that below 2 months ago he choked on food. So what do you understand by choking?
Again, food entering into the airways.
Uh, food which enters into the airway, why does food not enter the airway? And what happens if by chance we have a little bit of aspiration, if you are eating fast or or we are swallowing very quickly? What happens?
Reflex.
What happens?
Reflex.
Yeah, no,
yes.
we cough.
Yes, cough. Yes, again.
So, what is what is the typical situation in which we get choking on food? Is it because of more of a weakness, or is it a bulbar or pseudobulbar food? Is it because of weakness or a hyperactive gag?
Weakness.
Patients with weakness, they will aspirate and they'll be quietly be aspirating. So they don't actually have the true choking if they're actually coughing. If you say he choked on food but was not able to cough and protect himself, then this would be a situation where we would be thinking that the patient is would land up in significant problems. So it's not very clear whether he's got a hyperactive gag over here, or is it because of true aspiration, because of a pharyngeal weakness. If his nasal regurgitation had been clear cut, then we would say it's more weakness, because usually patients with pseudobulbar do not have nasal regurgitation as much unless it happens during a choking, where even before the soft palate is able to close off, they have a little bit comes out nose, but mainly it's actually a choking and their hyperactive gag, the equivalent of that, and they're just bringing out everything because they got like a equivalent of a gag reflex during that time. So it doesn't fit in with the food getting stuck in the throat and drinking water to elevate the sensation. Basically, what I'm trying to tell you is that when you're thinking of when you're listening to the patient, you should be trying to visualize what is the what aspect of normal swallowing has been affected, and take it backwards from the functions to the muscles serving it, and then to the nerves which are supplying it, and then going backwards to the brainstem, and then the upper motor neuron which is coming to the those cranial nerve nuclei. Okay. So he has some swallowing difficulties. We're not absolutely clear about whether he has. So he could have both element or and human or mixtures of both, but that's something that we'll have to see on examination. So as you're going through in the history, we're seeing that there are some aspects of inconsistencies, things that we need to look at closely when we're doing the examination, because examination is mainly for localization. To the history will give the diagnosis. Go to the next page. So he continues to take oral feeds, but his food intake is reduced. So food intake, the idea of asking for that is to say that the patient has significant swallowing problems or not. If he has significant swallowing problems, then only the food intake will decrease, right? And or otherwise it's because of some other factor. Okay, slurring of speech. What do you mean by slurring of speech over here? You gave some. There's no gap between the words. What are you trying to say by that?
There is no attacks in speech attacks. Pause between the syllables are not there.
Yeah, pausing between the syllables. But so the slurring of speech is likely to be due to?
Sir, bulbar weakness. There is only as he starts correctly, and as he continues to speak, the fluency gets worse.
Okay, when you think of speech, so this is something. What do you think? So suppose somebody has a weakness of the soft palate and having nasal regurgitation. What will happen to the speech?
Nasal talks.
So does he have any nasal twang?
Yes, sir. That's where the
No,
speech
you said that the nasal regurgitation is infrequent.
Yes, sir.
So does he have a nasal twang?
Yes, sir.
He does.
Yes, sir.
Oh, that you are going to say that on examination. Okay. What about the tongue and the labials, the linguals and the labials?
Normal, sir.
No, he's slurred enough that people are not able to understand him.
Yes.
So that's quite significant.
Yes.
So can pharynx alone cause that much slurring?
Only in stressing la 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 he has difficulties, sir. Labial.
So see, either he has phonation is reasonably okay. Yes. So you're saying that the volume of voice is all right.
Yes, sir.
So which means that his laryngeal functions are reasonably good. His nasal regurgitation, you're not very convinced about it.
Yes.
So the other thing that will contribute to the problems is the coordination between the tongue. The tongue has a significant role to play in speech, right? And particularly in cerebella, as well as in spastic speech, the patients may not have much swallowing problems, or not very significant swallowing problems, and be having more of speech problems. So is this a situation in which we're having more speech than swallowing problems? Food intake decreased tells us swallowing problems is reasonably significant. So and if we take that, does he have a weight loss? Did you ask?
No weight loss. No weight loss, sir.
There's no weight loss.
No weight loss.
So reduce food intake, but no weight loss. So then the reduce food. So then you're able to understand him when he's speaking?
Yes, sir.
You're able to understand.
He only gave the history, sir.
He only gave the history. So then probably this also is not very okay. So then there's no point in reading too much into it. but that's how you generally approach. So it's what do you think of when you have a patient who has significant slurring of speech but not much swallowing problems? Which are the, when you think of it, what are the prototype disorders that you think of?
The labial is predominantly of a tongue.
Yeah. So what are the prototype disorders that you think of?
So MND.
Right. MND involving, and why do they have in the beginning? Afterwards, of course, they develop definite severe swallowing difficulties as well. But at the outset, some often they have difficulty in speaking out of proportion to swallowing, and that is because of
Tongue atrophy, possibly.
yeah. So it's the UMN plus element tongue which causes more problems than the, as the pharyngeal functions are reasonably preserved and they're able to protect the airway reasonably well in the beginning. It's more of a tongue thing. Okay. So next page. Okay. Sleep. Yeah. What did you understand from this?
Sir, he's he speak he speaks in the sleep without.
Right. So what are the what did you understand from it? So you'll see that to be able to understand this, you'll be forced to read about sleep as well.
Yes.
So what are the stages of sleep?
Sir, REM sleep, NREM, stage 1.
So under ordinary circumstances, we go through stages of sleep where we become drowsy, and then we have the NREM sleep. Nowadays we call it as N1, N2, N3 sleep, and then we have REM. And then the cycles repeated themselves, right?
Yes.
How much time for a cycle?
90 minutes.
Approximately 90 minutes. Very
minutes.
good. So REM is the last part of it, and then again we go through N1 to REM. So what are the unusual things about REM? It's also called as paradoxical sleep. Why is it called that?
Consciousness will deep sleep, but it,
So during sleep, what happens is that in what is REM?
rapid eye movement distress.
So there are, so we have rapid eye movements during that sleep. But if we were to check their limb movements, suppose we were to put electrodes on their chin and their limbs and all, then the electrodes which were showing some amount of activity will become completely silent during that time. So even though the eyes are moving, the rest of the body becomes atonic. It's like switching off. The rest of the body is switched off. This is the phase of sleep during which we can have dreams as well. But under ordinary circumstances, we do not enact the dreams because we cannot, because the body's the tone is switched off. Except for the eye movements, nothing else is moving in the body. In fact, the electrode which is showing the chin movements will suddenly become flat. There won't be any movement at all over there also. That comes through various circuits, pathways in the brainstem and the which cuts it off during REM sleep. So, so during sleep, what you have to tell is that is he actually dreaming during that time? So this is actually called as dream enactment behavior. So he's seeing some dream, and under ordinary circumstances, we do not enact our dreams, but this person is enacting his dreams, which tells us what?
The tone is
That
increasing.
the REM during REM sleep, his muscle tone is not being switched off.
Yes.
Right?
Yes.
Do you know of any other situation where the opposite happens, that we are awake but the muscle tone gets switched off and we collapse for a few minutes? It happens in narcolepsy. We have sleep paralysis equivalent, and we wake up from sleep, but they're not able to move. They're awake, but they're not able to move. So they're awake, but thus the muscle tone is still switched off. So these are, it's quite fascinating actually, and we don't have all the answers for exactly how these things happen, but this is a fairly specific symptom. REM. So it would have been a little bit more specific if you had asked at what time does it happen. Why is that important?
At what time of sleep?
Because the cycle,
Cycle is-
you know, this
Yes.
cycle, and how many times in the night does it happen? It may happen once, 2, 3 times, but usually it not be immediately on going to sleep. It'll be about 1 to 2 hours later, usually 2 to 3 hours later. Okay. What about the tinnitus?
So it is not localized, sir. It is continuous and it is hearing bilaterally. It's not associated with decreased hearing. There is no ear pain or ear discharge.
A very significant tinnitus?
It's ongoing, sir, continuous.
Okay. How will you put it together with all the rest of the problems?
So along with other crane.
We'll see when you come to the final this thing, but at present I cannot put it along with the others. Go to the next one. Yeah. Anything inconsistent over here? Increased frequency of urination. What does that mean?
So
Increased frequency of urination?
often he has to go to urine.
No,
But
what does it mean in anatomical terms?
Low detrusor.
Intruser?
Hyper
Overactive.
overactive.
It's an overactive bladder. So the bladder, the detrusor muscle is supplied by
So, sympathetic, parasympathetic.
parasympathetic is giving rise to the contraction.
Yes.
So what does it mean that somebody has an overactive bladder?
Parasympathetic.
Overactivity. So your frequency of urination, urgency, urgent continence will go. But what about incomplete evacuation bladder? Does that happen because of the same mechanism? What does that mean? So overactive bladder from a lesion which is coming. You know about the micturition.
Yes.
So how does normal micturition take place?
So bladder fills, sensory in efferent pathway and detrusor contracts and then sphincter relaxes and.
So what are the centers which control this? Again, I'm just trying to show you that if when you're sitting or standing in front of a patient and listening to the history, to be able to analyze the history, you'll end up requiring to understand how each function happens. So what are the importance of the sacral areas? What is the parasympathetic, somatic, sympathetic? What is the pontine maturation center? What is the role of the paracentral lobule? So it's not necessary that you know everything. It's just the approach which is important. That you should think along those lines, and for a given patient you may have to analyze a little bit more when you have a little bit of inconsistency. So broadly speaking, we think of bladder symptoms as storage symptoms, voiding symptoms, right?
Yes.
So incomplete evacuation of bladder tends to imply what?
Storage.
Either the sphincter has not relaxed properly or the detrusor is not contracted enough. But on the other hand, we are saying increased frequency of urination, which means that the detrusor is overactive. So it's inconsistent, right? So, and that can happen when you have a detrusor, sphincter, dyssynergia. These fancy terms itself do not mean anything. It's what you have to understand it as is at a basic level of what is the storage versus voiding, detrusor functions versus the internal sphincter, external sphincter, and where we are having the difficulty. So, was he very consistent about the incomplete evacuation of the bladder? Or does he mean that he has to just go frequently?
He goes voids only 100 to 50 to 100 ml. He came within 5-10 minutes. He feels his bladder is.
So that's not really, that's just part of the frequency
Yes.
itself, no? Not necessarily sense of incomplete evacuation. Constipation.
He initially started.
Why does constipation have less localizing value than bladder symptoms for neuraxis? See, like for for bladder symptoms, we have the supranuclear, we have a pontine maturation center, we have and the frontal lobe, the paracentral lobule. We know that there is a specific pathway, and you know that there are some patients with pontine lesions who can have, or medullary lesions or cord lesions who can have significant bladder dysfunction, but usually bowel is not as badly involved. And why is that? Because the bowel has a very good intrinsic, the myenteric plexus can function quite well independently. So constipation may be there, maybe may or may not be related. It's possible that is modifying the water intake and those kind of things. It need not always. So the localizing value of bowel symptoms is relatively less unless you have like the anal sphincter is lost, and those patients will also have urethral sphincter also lost often. All right. Okay, now go to the next one. Right, this is also all negative. Next one. Next. Right. Okay, next. Okay, next. The So imbalance while walking and in coordination. So you're removing the sensory component, the proprioceptive you don't want to include over there. Bulbar symptoms in the form of dysphagia and dysarthria, bowel and bladder symptoms, tinnitus and RBD. So REM sleep behavioral disorder, you finalized on that. Okay, go to the next one. You multi-axial, predominantly cerebellum, brainstem, cranial nerves, autonomic dysfunction. So if it's only bladder, not necessarily autonomic, we say it's autonomic, but only bladder, yeah, on examination we find other things also possible. Brainstem, cranial nerves. This also we have not concluded whether it could be uh, uh, related to more of supranuclear like a pseudobulbar or bulbar, and on history, and cerebellum or its tracts. Yes. So it could be cerebellum or its tracts. Where is the tinnitus in this? That's where you're calling the eighth. Yes. Okay. Okay. So what's next slide? Etiological. Yeah, go ahead.
Immune mediated like anti-gliadin antibody related or hypothyroidism.
Okay, it's useful to group your differentials also. So you can put them as inflammatory disorders, and then 1, 2, 3, 4, what are inflammatory. You can put your degenerative disorders, nutritional, toxin, metabolic, as you can put them together. Hypothyroidism, good. So and then you should be able to also say that what are the things which make it more likely. So suppose the REM sleep behavioral disorder is very clear cut, then which one is most likely?
MSAC, sir.
Yeah, so that's what. So then you have to. So which means that you have to be go back into a little bit more detail on the REM, because there's nothing on examination that is going to give you what sleep. And if needed, you might even if you have a doubt, right, whether because degenerative, you have to be especially sure before labeling somebody as having a degenerative disorder, which means that you might even need a sleep study to be able to conclude on that. But there's nothing on examination which you're going to get. So that's therefore you have to understand the sleep cycle and then take more relevant history and try and increase the specificity of the history for the because generally we tend to think of the Parkinson's plus disorders. So what are the Parkinson's plus disorders?
So Lewy body dementia, corticobasal degeneration, MSA, PSP, sir. Progressive supranuclear palsy.
Yeah. So broadly speaking, we can divide them into tauopathies and synucleopathies. You can just remember that. And synucleopathies are the ones which tend to have REM sleep behavioral disorders, RBDs, and the synucleopathies are
MSA and PSP, sir.
MSA, not PSP. PSP is more of a tauopathy. PSP, CBD are all tauopathies. MSA, DLB are more of synucleopathies. Okay. Right. So paraneoplastic you want to put because to give benefit of doubt, and that's what we usually evaluate for if the symptoms are shorter than
1 year, sir.
2 years. Yeah. So if they're less shorter than 2 years, we can evaluate for that with this no family history. All right. Okay, carry on. Go to the examination.
On examination, he was alert, conscious, and oriented. He was well built. Height was 165 centimeter and weight was 85 kgs. Vitals at time of examination, his pulse rate was 86 per minute regular. Standing blood pressure, supine blood pressure at the right upper limb was 120/80, and standing blood pressure after 3 minutes again 120/80. Respiratory rate was 16 per minute, sir. There is no pallor, ictus, clubbing, cyanosis, lymphadenopathy, or enlarged lymph nodes. JVP was not elevated at time of examination, sir. Central nervous system examination.
So, go. So on this slide, uh, uh, which ones have become more important and less important in the context of whatever you told about?
This one, blood pressures, no drop.
So he has absolutely no blood pressure
drop.
drop. So why is that important?
Sir, in MSCC, autonomic dysfunction will be predominant, or in
Yeah, that's very specific. What we were discussing, that does he have autonomic involvement, broadly speaking? Paraneoplasty can also cause autonomic involvement, so that's not it's not just like MSAC alone. But he does not have any orthostatic hypotension at all. This is after how long?
3 minutes.
So then the question comes whether the bladder symptoms are autonomic or whether they are more related to the upper part of the bladder pathways. Okay.
Higher mental central nervous system examination. Higher mental function is right-handed, conscious and oriented, cooperative. Memory, reason, immediate and remote memories are intact, sir. Language and comprehension was also intact. Speech, so his I have video of his.
Okay, go ahead.
கண்ணை பார்த்து கண்ணாடி என்ற தலைப்புல ஒரு கவிதை. கண்ணை பார்த்து கருப்பு கண்ணாடி திறந்த பார்வைக்கு முகம் கொடுத்த வெள்ளை கண்ணாடி. இது நம் கண்ணுக்கு முன்னாடி தானே, இடதை கண்ணுக்கு முன்னாடி தானே இடதை விழதாகவும் வலதை இடதாகவும் காண்பது கண்ணாடி.
We're having an echo. Okay. But anyway, what did you interpret?
Sir, he's starting correctly though.
Talking correctly as in?
No, sir. Fluency is initially normal.
Fluency. Fluency we generally tend to use in examination terms more as a language function to be able to generate more number of words. In lay language, we tend to think of fluent as with clarity, but actually it's more related to how many words we can generate in a given period of time. So it's more of a language function, truly speaking. Actually, even in English language, fluency tends to mean more of that rather than the clarity of speech. Anyway, so not fluency, you're talking about the clarity of speech. So his speech is not clear.
Yes.
What is happening? He's mixing his words. His syllables are getting.
He's starting correctly, and as he speaks, his words are getting mixed up. Sir. Syllables
Mixed up. Yes. Okay, it's not separating out. It's getting mixed up.
Yes.
Okay, so that's a very non-specific thing. It can come from any part. It just means that. So then the next thing to do is to see which part of his speech is more. Is it that when he speaks faster, all syllables are equally getting mixed up? Then it could be just a tongue coordination kind of thing, and which can come from both UMN as well as cerebellar. He doesn't seem to be having the other component of the spastic speech, which is usually comes very early, whereas cerebellar scanning may or may not be there. But in spastic speech, they almost always have one thing which he does not have. What is that?
Strains and
he's not straining to speak. You're very right. He's not straining. There's no effort in his speech, right? Okay.
His cognition is also normal, sir. Model cognitive assessment was 27.
You did a MOCA,
yes,
rather than an MMSC. Any particular reason for that? No, you can defend it. What are the reasons why one would prefer a MOCA over an MMSC? It's what is the MMSC was described by Falstein, right? So what is the negative aspect? What are the things that MMSC is not powered enough to be able to elicit? The MMC is not very good at frontal lobe and executive functions, Whereas MoCA has some tests which are specifically for frontal lobe functions and executive functions. So while MMSE may have become more famous, MoCA is a more rounded screening tool, particularly in patients with these kind of suspected degenerative disorders, in which the only problem they may have may be a little bit of executive dysfunction. Okay. Sure. Next.
Cranial loss, olfactory is normal. Optic, the visual fields are normal. Visual acuity is also normal. Fundus is also normal.
Olfactory you checked and
Yes.
normal, or
Normal, sir.
how did you check?
So, coffee powder.
So each of these things, you are familiar with any objective measures for olfactory? Why am I asking? Why did I stop you at olfactory in this particular case? Is there any importance of the sense of smell and Parkinsonian disorders?
Clearly,
In which Parkinson's?
idiopathic.
In idiopathic tends to be involved earlier, right? Maybe expect it to be normal over here. But if you want to prove it, then how would you go about? Are there any more objective measures? There are some people who have come up with it. Some examiners may ask you about it. I am not very particular about it, but I think it's the University of Pennsylvania, UPSIT or some smell test or some. There are a bunch of tests which some people give a lot of importance to. So it may be important in a patient like this. You should know a little bit about it. In the exam setting, it's not always possible to do that. If you have to, if you get time, you can do it. But you should know just a little bit about it. What about the optic nerve? Was that important in any way?
Sir. Optic nerve atrophies can be syndrome.
So see, basically what you have to do is when you're doing your examination, you should always have your list of differentials in your mind. And at each place, is there something that you're going to find which could help you to move reorder the differentials that you have? Hmm? Anything on? So oculomotor, trochlear. So the third, fifth, fourth, sixth is all okay.
So saccades are broken on both sides.
Saccades are broken. What do you mean by that? You want to show it?
Yes.
What are you trying to show here?
So, there is incontinence.
Saccade is the quick movement meant for shifting shifting the focus from one point to another point. So saccades can generally you can have a problem with initiation of the saccade. The saccade can be slow, it can overshoot, it can undershoot and then correct itself. So those are the things that you have a problem with saccade because it is shifting from one point to another point. What is pursuit? Pursuit movements are to keep the eyes on a moving focus. So you focus your eyes on something which is moving. Saccades are much faster than pursuits. So generally we talk about broken is in pursuits. So the pursuits are not smooth, but the pursuits may be broken with saccadic intermittent saccadic movements because he loses the and then he makes a saccade to be able to catch the moving object again. And then he loses again, he moves. So broken is usually in terms of pursuits. And cerebellum, obviously, if they have flocculonodular lobe involvement, what do you expect to find? You expect to find nystagmus. Very good. So nystagmus coming from the flocculonodular lobe will be what kind of nystagmus? Gaze evoked, multidirectional in all directions. So the flocculonodular lobe is also called as, in physiology terms, vestibulocerebellum. So what are the functions of that? eye and
coordinate.
equilibrium. Eye and equilibrium. Spinocerebellum is so vestibulocerebellum, spinocerebellum, and corticocerebellum. Vestibulocerebellum also called as archi. Spinocerebellum also called as paleo, and corticocerebellum also called as neocerebellum. So spinocerebellum is more of
Balance
coordination, and corticocerebellum or neocerebellum,
muscle.
again coordination and speech also, right? Speech, we talk about the vermis as well, but the corticocerebellum, the dentate pathway outflow is also related for speech things. So we have the different nuclei, the fastigial nucleus and the flocculoneural lobe outflow is more for equilibrium and eye movements. And the dentate is the main outflow for the corticocerebellum, and it can go upwards as well. So the dentatorubro-thalamic pathways, and they are required for more finer functions, including upper limb coordination and speech as well. All right. So are his eye movements very, very prominent?
No, sir.
Abnormalities? Just show it again. Did you keep him at one side to show for nystagmus as well?
No nystagmus.
There's no nystagmus.
nystagmus.
Okay, move to the next. So his speech also is some slurring is there, but not very specific. What is next?
Trigeminal nerve is normal. Sensations were normal over both the sides of the face. Corneal and conjunctival reflex were present. Jaw jerk was absent, sir. Facial nerve was also normal. Not taste in the anterior two-third of tongue was normal in both the sides. Nasolabial fold is episode in both the sides. There is no deviation of angle of mouth, sir. So vestibulocochlear, considering tinnitus, we examined vestibulocochlear, but there is no ear conduction is more than bone conduction in both the ear, and then it is not lateralized to any sides.
Yeah, but which is the more important test that we would have looked for in this situation? What is the main purpose of Rennie's and Weber's?
Side to localization.
Yeah, it helps to differentiate between conductive and sensory neural if there is a hearing impairment, and also it helps to tell which side is more involved if there is one is relatively more involved. But what is the other third test that we do bedside? Absolute bone conduction, also called as Schwab's. Do you still discuss it? So that is, you compare the person's bone conduction with the examiner's, your own bone conduction, assuming that your bone conduction is normal, right? So that's in a patient with tinnitus, which is non-localized, that would probably have been more useful. Okay.
The gag reflex was
We just go back the previous slide. Facial, vestibulocochlear, then come down. Hypoglossal. Where's the
glossopharyngeal?
11th, 9th, and 10th you missed out.
So glossopharyngeal and vagus
Coming up.
So first.
Where? Oh, that's in the blue. All right. Okay. Right.
Gag was absent on both.
Gag was absent.
Yes, sir.
Okay. Gag was absent. So did he feel?
He's able to feel.
Sensations are present, but the gag was absent. So, so now we're in a little bit stuck over here, right? Did you expect gag to be absent? He looks fairly healthy. He doesn't look like he's run down. You told yourself he's not lost any weight. If you find that the gag is absent, before you conclude that the gag is completely absent, what else can you do? Neurological examination consists of, you can say broadly speaking, three things. One is observation. As the patient is sitting, you're watching him do the things that the normal movements and all. Second is functional assessment, where you give him, make him do certain things and see how he's performing the function. because what happens is sometimes they may have some ways to compensate for it. And then finally, you have direct examination by some standardized methods. At each point, you have to think about what is being brought out by anatomy. So when you say gag reflex is absent, what is the localization value with preserved sensation? So could it be that the gag reflex is relatively present, but the patient has, as you know, he's some people are very uh, careful not to cause any discomfort to the examiner and may tolerate it more. So before you conclude that the gag, and have you done it, or the other possibility is that have you touched the appropriate place? Where are you supposed to touch? Posterior pharyngeal wall,
Yes.
right? So if the gag is completely absent, that gives us a little bit of a problem in our list of things that we had, right? 'Cause what does it tell us? Gag being absent, that there is a low
Well,
motor neuron involvement with preserved sensory pathways.
Yes. Yes.
It cannot come from UMN. It cannot come from cerebellum, isn't it?
Yes.
So, so then, yeah, and and if it is the cranial motor nuclei supplying the pharyngeal muscles which are involved, then that becomes one more clear localization. So this would need to be checked. So what you do is you give them some water to drink, and then see how is he able to drink it well or not. And if he's able to drink quite well, that tells us that okay, maybe you need to check the gag again. Finally, of course, the decision is taken on the basis of a direct examination, but a functional examination can give us an idea that is it truly there or not. Okay, so hypoglossal is okay, spinal axillary is fine. All right, motor.
Bulk is normal. So tone is normal in both upper limb and lower limb, but in the right hand finger tap test is positive. So there is no.
So motor system again will be useful to. You've already finished the cranial motor system in part of the cranial nerve examination, but the only thing that you have completed in the neck is the sternocleidomastoid and the upper fibers of trapezius. So it's useful to also include this also in 4 zones: neck, upper limb, trunk, and lower limb when you're thinking about motor system. So there's no wasting around the neck as well. There's neck flexion extension is also normal. Just keep that in mind. Okay, so bulk, upper limb, lower limb, tone, upper limb, lower limb, normal. Go next.
So
Power is normal. Okay.
sensory system or sensations are normal. So both pain, touch, vibration, joint position sensation, cortical sensations are also normal. So reflexes, superficial abdominal reflexes present in all quadrants in the abdomen, sir. Deep tendon reflexes in the upper limb is 2+, sir. Lower limb, the knee bilateral, it is pendular knee check, sir. And in the angle reflexor absence.
So what is the mechanism of a pendular knee jerk?
I don't.
Go back to the previous slide. So so don't think of pendular knee jerk cerebellum. It's pendular knee jerk is because of something which is could be related to cerebellum, right? So that way, if you always use the slow system of your thinking process, you will be forced to look at all the aspects that lead up to that. So then you will not have these inconsistencies. Okay, come. Are you going to demonstrate?
Yes.
Okay, good. Sure. So how many movements are needed for pendular knee jerk?
Three, sir.
Three and a half. So these are again things that people have tried to make, and often you'll find the references for that will be from some textbooks from either Calcutta or from Chennai. All right. It's just basically it's an if you are interested in all these things, you can actually do you can design your own study to be able to look at normatives and patients with pure cerebellar disorders and decide whether you have a good cutoff for for 3 or 3.5. Some people will insist that it should be 3.5 movements. Anyway, okay.
He has got to got dysdiadokinesia in both the sides.
Okay, sure. Okay, so this is absolutely clear cut, right? Okay, next. Who took the video?
So patient son.
Son.
Yes.
So what are you seeing over here? So what is the role of the cerebellum in this particular action that he is doing?
Fine movements and coordination.
Yeah. So no. So what are so there are many things that are required over here. No? You have to be able to put the finger properly on the nose, then move it smoothly till the other till your finger and touch the tip of the finger and then come back smoothly over here. So what are the things which are abnormal over here?
So initiating itself is
So when he's not able to put his finger at the tip of the nose, what happens at that time?
Sir, he's finding somewhere.
What's that called?
So
you can either be a pre or past pointing, or it could be a dysmetria where he's not able to judge the range of the movement. And as we make it faster, it becomes more abnormal. Similarly over there, there's one more thing that comes up in this test is called as intention tremor. What is that? In here, for him, it is not very prominent. Just see it again. What is an intention tremor? Go back to the previous one. Finger nose, yeah. Yeah, when it comes back to the nose, we can see it, and occasionally we can see it when it comes more better on the left. And when they're coming over here, the movements become. It's not a dysmetria will be along the axis of the movement. Intention tremor is perpendicular to the axis of the movement. As they come to the end, they will have a little bit of a tremor. That's all right. Okay. Some people would argue that in a patient where you have got already shown upper limb in coordination, why would you do a Romberg's? What did you do before that?
This data.
No, you already done that. You showed that. So when you're examining lower limb, is he able to stand with his eyes open?
Yes.
Did you make him write?
Sir, yes, sir. I didn't.
You have a handwriting video?
I have.
His handwriting you have? Okay, sure. Okay, sure. Whatever you have. So he's he was stable with his eyes open?
Yes.
From the beginning of the video, his eyes are closed.
Closed.
So is he able to stand with his eyes open?
Yes, sir.
But you feel that there is some sensory ataxia as well?
Yes. But there is no findings to. But sensations are normal.
So see again the same principle. You have to decide which way it is. So either there is a problem with the examination of the Rombergs, or there's a problem in the way we have examined the proprioception. So let's go back to that proprioception slide. What did you do over there? So vibration, how did you test?
So, and the joint 126.
Vibration, how did you test at the joint?
At the joint.
With which tuning fork?
126.
What was the duration for which he was able to feel?
Till that.
So the duration is important. Joint position, when you tested, how many degrees did you move the toe?
40.
And did you give him adequate
10 types.
Yeah. So did you compare the upper limb
With the
joint position, how fast he's responding in the upper limb versus how fast he's responding when you're doing the lower limb toes? So those are small things, but that increase there could be a difference between the two, right? Because your ankle jerk is also dropped. So that also tells us that you have. So what does it mean, ankle jerk being dropped? What are the possible explanations for an ankle jerk being dropped?
neuropathies, large fiber.
No. Again, you're jumping straight to nerve. What is it? What is ankle jerk? What are you stimulating? What are you and what are you? What response are you looking for? What is the center?
Contraction of the hamstrings.
So the ankle jerk is dependent on what? Any deep tendon reflex? What is it? What are you stimulating?
Contraction of the muscle.
No. What are you stimulating? It's a
Flexion,
stretch reflex also called. No? So what are you stretching?
It's a 10.
No. What is the role of
Flexor.
the muscle spindle? What is muscle spindle? So to be able to understand that, you should know that where does it come from? So what are the types of fibers, large versus small? What are the extrafusal, intrafusal? So what are the sensory pathways from the muscle spindle? It's a monosynaptic reflex which comes back to the extrafusal and to the intrafusal via the gamma and the alpha. It's all taught actually. It's all you've done in anatomy physiology. It's there in physiology textbooks. I hope it's still there in the physiology textbooks. Is there? Yeah. So it's basically the same principle. The muscle spindle and this muscle spindle is something that CMC Dr. Marcus Devanandan has work on muscle spindle in his, which was quoted in Gray's as well. So the muscle spindle is a very important aspect of the local arc. So the larger fibers are the ones which supply to that. So you understand that, you'll be able to say that, okay, if the ankle jerk is gone, is there a large fiber neuropathy? If there is, then why is the proprioception and the joint positions absolutely normal? So there is a little bit of a mismatch over there. So we'll go further. Gait. When do we say somebody has a broad base? Wide base.
Wide apart.
So you'll find that somebody would have, given some. There are some references to say that 12 centimeters, more than 12 centimeters apart. So if you want to say a wide base, people will make you, mark the steps and see how wide the base of the gate actually is. Doesn't look too wide, right? So again. Right. You've found, in fact, that his upper limb incoordination was quite clear cut.
Yes.
Cerebellar syndrome. Okay, what else? Where's the rest of it?
Bulbar palsy.
That's because the gag reflex was absent.
Yes.
Where's the rest? Where's the neuropathy? You're saying that ankle jerk is dropped. So you're ignoring the dropped ankle jerk and the Romberg's. So suppose you have a Romberg's positive and you want to differentiate a posterior column versus a neuropathy. How do you do that? If there's a posterior column involvement which is causing a sensory ataxia versus a large fiber neuropathy which is causing an ataxia. Forget about everything else which may or may not be involved. When can you say that this ataxia is more likely to be peripheral nerve, and when sensory ataxia, and when do you say it is more likely to be posterior column?
Distal weakness.
That's motor. We're talking about sensory. So that's the importance of the ankle jerk. In a proprioceptive impairment, due to posterior column involvement, the reflex arc is paired. It's the large fibers from the muscle spindle, the type 1 and type 2A fibers, which carry the sensory component of the reflex or the afferent of the reflex, to which goes to the alpha and gamma motor neurons and comes back to cause the extrafusal part is the one which causes the muscle contraction. So if the 1A, 1 and type 2 fibers are intact, the ankle jerk will be intact, which will be expected in the proprioceptive, whereas it will be the first thing to be lost in somebody with a sensory ataxia due to large fiber nerve involvement. All right. So, okay.
This is the MRI of our patients. Shows cerebellar atrophy at pons and middle cerebellar peduncle.
What are you trying to show in this?
So there is atrophy of cerebellum.
Show it. Which part of the cerebellum is this?
So, floccular nodular.
Is this the central, the vermis of the cerebellum? This is the sagittal section through these midpoint. Right? So what else is seen? The pontine belly is not as prominent as you usually expect it to be, right? The pontine belly is actually like a proper belly. It's a little flattened out. And the medulla also, this you cannot say on this section, but on axial sections, you can look for olivary atrophy also. What is the olive? In the brains, in the medulla, we have adjacent to the pyramid, lateral to the pyramids on both sides, which are the most anterior medial structures, is the olive. The inferior olive is actually a wider and larger bump on the axial images than even the pyramid. And that also becomes atrophied. And then we call it as olivopontocerebellar, OPCA atrophy, which is considered to be fairly typical for MSA-C. It can also be seen in some of the spinocerebellar atrophies. It's not very specific. And for that matter, even paraneoplastic cerebellar degeneration can also cause cerebellar atrophy. Go back to the previous slide. Almost all of them can cause cerebellar atrophy. So it's not very specific. So unless you see some signal changes or something, then only you can say. His gait is relatively well preserved. Okay. Any questions from anybody? We overshot time by about almost 15, 20 minutes. So what do you think about your presentation? You actually did quite well. Seriously, from a medicine PG point of view, you're in a second year now? Third year now. So just a little bit of fine tuning, a little bit of looking at the things from a slightly different perspective. Okay. Is all that you need. Otherwise, you're putting things well. Go by anatomy, and so that the consistencies, the internal consistencies in what you're saying will become more, because whenever you're speaking, the examiner sitting in front of you is thinking along lines of anatomy and physiology. Which textbook of internal medicine do you read now? Harrison, sorry, right? So there's something I've told several times, and you'll find references for it also. The discussion between Tynell Harrison and Raymond D. Adams. So Tynell Harrison is the one Harrison's textbook of neurology. Yes. Raymond D. Adams was one of the early. He was a neurologist was one of the major contributors for the Harrison's textbook. The symptomatology section is Raymond D. Adams' idea, that to analyze all the symptoms in detail. And the way he did it used to irritate Harrison. and you'll find references for this. So Taylor Harrison is famously known to have said that, why don't you go and rename the book as Principles of Internal Medicine and Details of Neurology, and because of which Raymond D. Adams came out afterwards with which other book? Principles of Neurology. Came out separately with Morris Victor. I think some of the forwards from the 12th edition of Harrison onwards, this thing is mentioned. If you go online, you just might be able to find this also. Okay, so symptomatology is extremely important. That's basically what we do. That's the clinical method. Try and understand the symptoms and the signs in terms of structures involved, then localization, and then etiology in terms of pathophysiological processes, and then finally specific etiology in some situations. Okay, so for example, the clinical examination is mainly for localization, but if you find a KF ring, it makes it more likely to be a Wilson's disease. For example. So general examination can help you towards etiology, but clinical neurological examination is for improving